today we are going to discuss about pulmonary arterial hypertension. In this module, we shall be overviewing how to make a diagnosis of pulmonary arterial hypertension, understand its pathophysiology, diagnostic approach and management. All of us know that pulmonary artery, they are low pressure channels which take the blood from right heart to the lungs. It is also a fact that lung is the only organ which receives all the cardiac output. What is important is that the physiology of this is different from systemic circulation, and normally pulmonary arteries are in a state of vasodilatation. If you see this particular cartoon, here you will see that it's a low pressure system, and in these cases the blue one depicts the pulmonary, in these cases if you see it, the blue one is the venous circulation, and in this the right side of the heart sends the blood to the lungs, where it gets oxygenated, comes to the left heart. And the pressures usually vis-a-vis systemic circulation is much lower, and average mean pressure here is 14 millimeters of mercury, whereas ranges from systolic pressures in this is 25 and diastolic pressure is 8. Now, when we talk in terms of pulmonary hypertension, it means the blood pressure in the pulmonary circulation has gone up. That's what it means. But it is a heterogeneous group of disorders, but there are common histological abnormalities and the same pathophysiology. In simple words, if I say so, is that the factors which lead to pulmonary hypertension are numerous. The disease etiology is heterogeneous, but they have one similar physiological consequence, that is of increase in blood pressure in the pulmonary circulation. Now, this in terms elevation of pressures in pulmonary hypertension in pulmonary artery has a secondary effect on the right ventricle, leading it to hypertension, to its hypertrophy, dilatation and failure. In this strain or this hypertrophy of the right ventricle can also precipitate features like angina. Persons can feel shortness of breath, and there can also occur raised elevation of JVP along with pedal edema and hepatomegaly. Therefore, pulmonary hypertension is a pathophysiological disorder which involving multiple clinical conditions and can complicate the majority of cardiovascular and respiratory disease. And the reason is very simple, because in both sides of the heart, the right and the left, you have the lungs, and the circulation to the lung, the blood goes from the right heart, and as I said before, it is a deoxygenated blood, and the net result is, like systemic hypertension, you have an elevation of blood pressure in the pulmonary arterial tree, and that is what is called as pulmonary hypertension. Therefore, when we need to define it, it is defined as an increase in mean pulmonary arterial pressure to more than 25 millimeter at rest as assessed by right heart catheterization. That means the measurement ideally should be done by the right heart catheterization, and what we see in these cases is that when the pressures that go beyond 25 millimeters of mercury mean pressure, which usually is 14, then you label it up as pulmonary arterial hypertension. Now, this is again a group. When we are talking, this is what we define, this is how we define pulmonary hypertension. Then how a pulmonary arterial hypertension is different from pulmonary hypertension. Now, pulmonary arterial hypertension is a subgroup of patients of pulmonary hypertension. It has the similar features as you see in PH, that is in pulmonary hypertension. And what we see, however, the difference is here the pulmonary hypertension is because of precapillary abnormalities. That is, presence of precapillary pulmonary hypertension is by pulmonary artery wedge pressures are less than 15 millimeters of mercury and pulmonary venous resistance more than 3 Woods units. And there is, along with it, there is an absence of other causes of precapillary pulmonary hypertension, like pulmonary hypertension due to lung disease. You can have a chronic thromboembolic pulmonary hypertension or other rare disorders. In simple language, if I simply say, is that a subgroup of pulmonary PH is a subgroup of pulmonary hypertension where Precapillary abnormality is responsible for the elevation of pressures in the pulmonary circulation. And provided we can exclude cardiac and respiratory and other disorders like chronic thrombopulmonary embolic disease. Now, if we need to classify the pulmonary hypertension, we divide them into 5 groups. Group 1 is called as pulmonary arterial hypertension. Group 2 is because of left heart disease. Group 3 is because of lung disease or chronic hypoxemia. Group 4 is because of chronic thromboembolic pulmonary hypertension or because of pulmonary arterial obstruction, whereas a group 5 is associated with multifactorial etiology. Group 1 is further divided into 1 prime, what is called as a pulmonary veno-occlusive disease or hemangiomyomatosis. On the other hand, 1 double prime is called persistent pulmonary hypertension of the newborn. So this is the classification of pulmonary hypertension which we need to know, and as it is very clear from this classification that it is a group 1 pulmonary hypertension which we labeled as pulmonary arterial hypertension. Now, when you start looking at the classification of pulmonary arterial hypertension, again it is subdivided into various parts, and one of the most important part out of them is a idiopathic. That means we do not know the etiology. Second important is a heritable, which could either be because of BMPR2 mutation or could be other mutations which are unspecified and defined. It could secondarily to be drugs and toxins, and can also be associated with connective tissue diseases, HIV virus, portal hypertension, and congenital heart disease or schistosomiasis. So there is a large group of differential diagnosis even for pulmonary arterial hypertension. Now let's look at the pathogenesis. The increase in pulmonary vascular resistance which is seen in PH is a large number of changes which takes place in pulmonary circulation, and one of the most important is vasoconstriction, and second is an important issue is obstructive remodeling of vessels because of proliferation of cells, as you see in connective tissue diseases. There could be inflammation of a vascular tissue, or there can also occur in situ thrombosis associated, and most important, as you looked at it when we are defining the subtypes of PH, are genetic mutations which predisposes to these things. Now let's look at it. There could be a genetic predisposition or there could be a risk factor. Now genetic predisposition, we usually see it in BMPR2 mutations or ALK1 mutations. There can also be 5-HT polymorphism, and along with it the risk factors are in the form of the drugs or in terms of infections or the amount of blood which is being flowing. And the most important infection which is associated actually is either HIV or schistosomiasis, and certain anoxigenic drugs, that is the drugs which reduces the appetite and help us in reducing the body weight, can also be associated. Portal hypertension, since we are doing a liver transplant, we are seeing an increase in the incidence of the patients developing portal systemic circulation or portal hypertension in the pulmonary arterial hypertension in these cases. Once we see that there is a pulmonary vascular damage, what we see along with it, 3 things can happen. Either you can have an endothelial dysfunction, or you can have a small smooth muscle cell dysfunction, or there can be matrix changes in the platelets and inflammatory cells activation leading on to in situ thrombosis. So the net result is going to be 4 components of it: A, vasoconstriction; B, proliferation of the blood vessels, along with inflammation and thrombosis. Net result is going to be increase in pulmonary venous resistance, which will be manifested in the form of elevation of pressure, which we called as pulmonary arterial pressure, and that is how the pulmonary arterial hypertension develops, and there occurs, and subsequently if these risk factors continues to be there and this inflammation or the method, or it initiates the inflammation if it persists, or there occurs the superadded in situ thrombosis or continuous vasoconstriction, then this will continue to progress over a period of time. When you do a histology, the most important feature of pulmonary arterial hypertension we find is that all the 3 cellular layers, in this case both intima, muscles, as well as the outer sheath, all 3 components, they tend to show a hypertrophy dominantly by the muscles. And there, along with it, there occurs plexiform lesions, which is nothing like but there's a bunch of grape-like lesions which you tend to see it and associated in situ thrombosis. So what you see, there is a thickening of the intima, media and the peripheral sheath with the development of plexiform lesions and in situ thrombosis. This is a classical one which you will see it here. In this case, there is a thickening of intima, endothelium which is there, and then media and smooth muscles are there, and the outer sheath which is there, which is adventitia, is also enlarged. So this is how we are going to see in this case. Dominant feature will be endothelial proliferation with fibrosis, and once intimal fibrosis occurs, then practically it is non-reversible with the medial and smooth muscle cell hypertrophy, and follow in between by in situ thrombosis. And this is a plexiform lesion which is there. You will see a collateral flux which is coming up, and these are the lesions which are on the outside and can lead to alteration in physiology and the pattern of blood flow in the pulmonary vessels. So when you start looking at the mechanisms and pathways, what we see here is that there is two things which are important in the pulmonary hypertension. First and foremost is endothelial dysfunction. You see endothelial cell dysfunction, which can ultimately lead to intimal fibrosis, vasoconstriction, and increase in PVR, as well as alteration in blood flow. And that is what we see here is increase in PVR, that is pulmonary vascular resistance. And what you see is the endothelial dysfunction is either because of endothelial pathway, or it could be prostacyclin, which is responsible for vasodilatation, and third is nitrous oxide pathway. In this, all these pathways are associated with vasodilatation, and what we see here is endothelin is usually associated with significant vasoconstriction, whereas the prostacyclin and nitrous oxide is associated with significant vasodilatation. So the net result of all this is when these things they go abnormal, you have an increase in pulmonary venous resistance, and these are also the basis of treatment of patients of pulmonary arterial hypertension. Endothelial dysfunction obviously is associated with reduced production of vasodilators, increased production of vasoconstrictors, along with it leads to endothelial smooth muscle cell proliferation, and net result is increase in pulmonary venous resistance. When this increased PVR occurs, it puts an additional load on right ventricle, which is a thin chamber leading on to right ventricle hypertrophy, because hypertrophy is a consequence of increase in afterloads, and when this occurs, the right ventricle starts dilatation leading on to right ventricular dysfunction, evidence of right heart failure and right ventricular failure leading on to death. That's how it is there. Now WHO defines into different functional classes, which we have a functional class 1, functional class 2, 3 and 4. Functional class 1 is when the patient has a pulmonary hypertension, but there is no limitation of physical activity, or there are no clinical signs and symptoms. That's an important point to remember. As far as a functional class 2 is concerned, they have some limitation of physical activity. They are comfortable at rest, but what is important is that ordinarily physical activity is going to cause unusual breathlessness or fatigue, and this is how commonly these patients present to us, and rarely you will find evidence of pain, chest or syncope. As the functional classification person deteriorates, you can very well mark that there is a significant or a marked limitation in physical activity. Patient will be comfortably less, but what is important from the class 2 is that less than the ordinary activity or day-to-day activity will lead to unusual breathlessness or fatigue, and there are a significant number of these patients may complain of syncope or chest pain. Whereas the functional class 4 patient, which is the most advanced and serious form of this disease, they will not be able to carry out any physical activity without symptoms, even in day-to-day activity. And these patients are actually going to have a signs of failure of right heart. Along with it, you may be finding these patients complaining of breathlessness and tiredness at rest. And any increase in physical activity is going to be associated with worsening of symptoms. And it is important for us to know these functional classifications because they are associated with survival. Patients who have got a functional classification 4, they have a poor 3-year survival vis-a-vis persons who have got functional 1 classification. Therefore, when you make a diagnosis of pulmonary arterial hypertension, that is not good enough. What is equally important for us is how much physically impingement this elevated pulmonary arterial hypertension is putting on the patients, because that is what is going to prognosticate more than anything else. Any improvement in functional classification on treatment is associated with decreased mortality and morbidity in patients of pulmonary hypertension. When we look at the epidemiology of pulmonary hypertension, what we see is it is different among different groups. Though it is best studied in group 1, where you define as a pulmonary hypertension. Idiopathic heritable PH are usually rare in the general population and incidence is extremely low. In India, still we don't have a data, but from the European data, whatever we have it is 5 to 15 cases per 1 million. When we start looking at EPH, again, as I said, it's an extremely uncommon disease. But out of them, when we look at it, and the particular and the genetic mutations and other things, idiopathic is the most common form. And interestingly, it is far commoner in women as far as men is there, and affects the younger people. And PH patient pool is becoming increasingly complex because they are surviving a little longer and they have got significant associated comorbidities. If you see it, the predicted survival, when you see the NIH history which is there, predicted survival rates was 69%, 56%, 46 and 38 at 1, 2, 3, 4 years respectively, depending upon the stages after making the diagnosis of pulmonary hypertension. So that means as the duration increases, chances of probability of persons dying with the disease increases. Let's look at as a case scenario. A 17-year-old girl presented to us with the sign and symptoms suggestive of connective tissue disease. That is, she had a Raynaud phenomena along with skin rash for 2 years. She was also started complaining of shortness of breath for last 6 months. When she came, her pulse was 90 per regular. She had a blood pressure of 98 by 60. She had a saturation which was mild hypoxemia was there, 93%, which we could see it. She had a rash on the face along with telangiectasia. Auscultation, we could auscultate P2 loud, chest were clear, and there was a mild pedal edema with elevation of JVP. Biochemistry was unremarkable, and what we found out, she had an elevation in platelets with mild elevation in ESR. X-ray showed cardiomegaly with the pulmonary prominent in this case, along with ECG having right axis deviation, right ventricle hypertrophy with strain and P pulmonale. Now this is an X-ray of this girl. What you can see is a massive cardiomegaly with enlarged pulmonary conus, enlarged, obviously, which is telling us enlarged pulmonary artery. Right side, you can also see it, and a pruning or oligemic peripheral fields and evidence of cardiac enlargement and what you say dominantly of a right ventricular variety. ECG is showing in this patient evidence of right ventricle hypertrophy and P pulmonale. When we did additional testing, PFTs were normal, and along with it what we find inspiratory expiratory pressure was okay. 6 minutes she could only walk 175 millimeter and she desaturated during this 6-minute walk test. Antiphospholipid antibodies were negative and she had a positive ANA and anti-dsDNA. Both rheumatoid factor as well as anti-scleroderma, anti-SCL70 were negative. When we did an echocardiogram, we found a florid evidence of pulmonary arterial hypertension in the form of right ventricle hypertrophy with paradoxical septal motion, right atrial enlargement, and there was associated significant tricuspid regurgitation, which told us that pressure systolic was around 80 millimeters of mercury. CT scan, you can see double the size of aorta, and whenever we see a size equivalent to aorta of the pulmonary artery, that means it is significantly enlarged, and there is increased RA-RV. Therefore, the diagnosis in this patient was a patient having a pulmonary hypertension with the connective tissue disease, and the diagnosis which we made of the connective tissue disease was systemic lupus erythematosus. So this patient's full diagnosis was SLE with pulmonary arterial hypertension. So when you look at the PH, therefore this case highlights the problem which are associated with pulmonary hypertension in terms of diagnosis, and when this girl reached to us, already she had a very advanced disease in a very short duration of time with an active connective tissue disease. Therefore, it brings up to another thing, how can we detect it early? For that, we need to have a screening program, and early diagnosis and therapeutic intervention can help improving the outlook. Otherwise, outcome at this level when we start treating is dismal. Now, we need to identify high-risk population, and any person who has got a heritable pulmonary arterial hypertension, they are at risk. Same is the persons who have got a systemic sclerosis, HIV, or persons who have got a portopulmonary hypertension, and patients who have got congenital heart disease. They need to be looked up for the evidence or the development of pulmonary arterial hypertension closely. European and US guidelines now recommend annual screening of high risk of patients with Doppler, and echocardiography, which is a non-invasive tool, has become the procedure of choice in following up these cases as well as in screening. Now, without screening, when you see the majority of the patient will be diagnosed in functional class 3 or functional class 4. Our patient was in functional class 2 though, but what is important is, if we don't, only 24% patients will be picked up in the early diagnosis. On the other end, when you do it, you pick the patients early and you can then alter the natural history of the disease. Therefore, important for us to pick up, and you see more than twice we could pick up with early screening the patients, and hence the standard recommendation is all the patients who have the so-called defined risk factors for pulmonary arterial hypertension be screened, and try to pick them early so that you can treat the cause which is causing it, or alternatively the disease itself rather early. So that screening tool, as I said before, which should be easily available, expertise should be available, and it should preferably be non-invasive. And these cases, what we are looking at it today is an echocardiography along with the biomarkers like proBNP, etc. As far as the patients who have got a systemic sclerosis, it is important because connective tissue disorders are associated with the elevation of pulmonary arterial hypertension. Not only that, they have a significant number of these patients have pulmonary involvement. Any person who has got DLC less than 60% of predicted are the ones which needs to be there. A word of caution here, scleroderma patients can straightaway also present with pulmonary arterial hypertension, or other connective tissue disease patients can also present it. So anybody who has enough evidence of interstitial fibrosis in the setting of CTD, preferable is that you pick them early so that they can be treated, and it is important to differentiate at that point of time secondarily to chronic hypoxemia. As far as the diagnosis is concerned, it is a challenge, but at the same time, we need to know a series of investigations which are important. And the investigation and the history taking is the key, because that will tell us making a differential diagnosis, and then which test to be done, and then making a probable etiological diagnosis, and then we can have a battery of tests according to that. Once you have made a diagnosis of a pulmonary arterial hypertension, it is important to know the physiological or hemodynamic consequences of it, because that is what is going to define the prognosis of these cases, and the ability and the treatment strategies will actually based on the functional classification of pulmonary arterial hypertension. Now, this is the algorithm which was given in 2009 in circulation, and I still feel is very appropriate. The most important test, as I said, will be history examination, chest X-ray, as we have shown you, in electrocardiography. Once you have done it, this will lead to index of suspicion of pulmonary hypertension. Once that is done, you take these patients for echocardiography, and when you do an echocardiography, it will also able to tell you whether person has got a right ventricular dysfunction or not, or an evidence of pulmonary arterial hypertension or not. Along with it, will also tell you or rule out the left heart or other abnormalities cardiac abnormalities which may lead to elevation of pulmonary pressures. Once that is there, then the next thing is to do VQ scan and PFT. VQ scan is going to, if it is suggestive, then it is better to go for CT pulmonary angiography. If you do not have the ability today or a facility for VQ scan, then CT pulmonary angiography is very important tool, and it can help you picking up chronic thrombopulmonary embolic disease, which has a treatment today in the form of both oral anticoagulation and, if need be, surgery. Then we do a pulmonary function testing, for which we do along with it blood gases as well as PFT. And in the PFT, we also simultaneously can practice overnight oximetry. Now, all these things will tell us in terms of looking what are the ventilatory functions or any disease which is a primary pulmonary component which may not have caused the pulmonary hypertension, you can pick them. If you do overnight oximetry, if you find there is a desaturation of more than 4%, then it will point towards associated sleep apnea syndromes, or if somebody is obese and is having abnormal blood gases, then you can also look at obesity hyperventilation syndrome. Then obviously we will be needing, if there is a history of multiple partners for the HIV, and in the young females and people, you can also go for a connective tissue disease, and there you will see ESR will be markedly high, and then you do an ANA, which can be a screening test, and once that is positive, then you can go for extractable nuclear antigen to know and define the causes. And obviously functional test in terms of 6-minute walk test or cardiopulmonary exercise testing give you a functional status. Sometimes we may even have to do an invasive cardiopulmonary exercise testing actually to know the physiological or the cause of breathlessness or to confirm the diagnosis of pulmonary arterial hypertension. But what is important is they are telling us about the prognosis. And the final and the gold standard for the diagnosis continues to be pulmonary angiography. And when you do a pulmonary angiography in these patients or right heart catheterization, you can do a vasodilator test which will confirmation and we'll talk about the hemodynamic profile and vasodilator response. So when you do this right heart catheterization, you do vasodilator test, exercise RH cath, that what I said, invasive cardiopulmonary exercise testing, you can say so, and you also can do and see the response of a volume loading and left heart cath. So the net result will be, this is the sequence which we need to follow up. You can make and suspect on the clinical grounds, confirm, partly it will be confirmed on the basis of echocardiography and it will rule out left heart causes. You do a pulmonary function assessment to rule out pulmonary causes, and then if you're suspecting today, you can do a CTPA, that is a CT pulmonary angiography to rule out the evidence of chronic thrombopulmonary embolic disease. And if there is a history suggesting of Raynaud, there is a history suggesting Malheur rash, or there is a recurrent ulcerations, etc., or you have an evidence of interstitial fibrosis, at that point of time you can always do a test to rule out both all the connective tissue disease as well as any prothrombotic state. Once that is there, you do a cardiopulmonary exercise testing to simply assess the functional status, and then ideal would be to do a pulmonary cath, right-sided, to know the vasodilatory responses, to know the response to an exercise, and also to see in these cases a left heart to rule out any missed cause of right heart failure secondarily to congenital heart disease. So the next slides again summarizes as a clinical suspicion, which as I explained will come up. Then obviously you can also exclude group 2 and group 3 PH, which is there. Group 4 PH, as I said, is nothing else but your chronic thrombopulmonary embolism, and obviously PH evaluation by CT pulmonary angiography or cardiac MRI today can explain, can prove or disprove secondary causes of pulmonary hypertension in these cases. 2D echocardiography is an important screening tool, and the TRJet gives us a fair amount of an idea whether the person is having pulmonary arterial hypertension or not, but it is an operator dependent, and additional hypoxia or other factors which can cause altered pulmonary vascular characteristics can change or can make a false diagnosis. So this could be an unusually sensitive test, but at the end of the day, it's an excellent tool to confirm the diagnosis, but the gold standard continues to be right heart catheterization. This is the problem which you see with 2D echo, which I said, no single echo measure able to diagnose pH. So what is very important, you are making a conclusion of pH indirectly. That is why we are saying it. Underestimation of pressures due to eccentric tricuspid jet is not an uncommon, where these are the pitfalls of the technique. But at the same time, the technique is good enough to pick up and help you in warranting further studies in these patients. CT scan, normally we don't do it, but when you are suspecting group 3, in these cases group 4 disease, especially chronic thrombopulmonary embolism, this is a modality of a choice, and it can also rule out structural damages to the lung, which may have been missed otherwise on plain radiology. And whenever you will find that there is an increase in the diameter of the main pulmonary artery of around about nearly 3 centimeters or more, then you have a sensitivity and specificity of 69% and 100%. Similarly, you can also look at the pulmonary trunks in the hila, but most important practical tip is that if you see that the pulmonary artery diameter is equal or more than the aorta, that means there is an evidence of pulmonary arterial hypertension. Gold standard, I said, it continues for the definitive diagnosis to have a severity of hemodynamic measurements or impairments, and also to look at the vasoreactivity, which will tell us whether this person has got a fixed changes or have a reactive changes, and which drugs to be used in these cases. So that's what we do it. Characteristics, it's an important tool, and obviously there are very few specialized laboratories today available in the country who are actually on a routine basis doing it, and should emphasis should be, especially in the Department of Pulmonary Medicines, to have right heart caths. Now let's come down to the management. Most important is why we need to treat the underlying cause of pulmonary hypertension, which has caused and precipitated the abnormal hemodynamics in the pulmonary arteries. Currently, we must remember there is no cure of pulmonary arterial hypertension, that means group 1, which we are talking of. Modern advanced therapies improve patient symptoms and slow the rate of clinical deterioration, and helps therefore decreasing the morbidity and mortality. That is important. Management usually tends to be complex. You need specialized trainings in it, and it involves a range of treatment options, starting as usual from the general measure to conventional supportive therapies, or you try to give advanced treatment in term which is specific to the endothelial activity, and looking and taking advantage whether the pulmonary artery are reacting or not, and the surgical intervention can also be done in certain cases. General measures, as I said, commonly it is a disease which we see in females, therefore they are young, and hence pregnancy avoidance is essential, and there has to be a prompt treatment of chest infections which are there. Genetic counseling becomes an important issue where we find hereditary things, because they have an autosomal dominant as well as recessive, both patterns are there. And it is important is that you want to limit the extent. Why are we looking and emphasizing on general measures? Aim is to decrease the influence of external factors. Vaccination, if you do it, well and good, and in adults, it is important, as I said here in written areas, all age appropriate vaccination should be there, and they are not contraindication. These are the summary of recommendations which we have just discussed. Exercise training is important, and it is beneficial. It intends to improve the quality of life, and also not only improve the quality of life, but it tends to improve the WHO functional class, and if you improve the functional class, the prognosis improves. However, it will have minimal or no effect on hemodynamics. Supportive therapies are important, because though in pulmonary arterial hypertension we may not see primarily in situ thrombosis always, but usually they are a supportive. There is a significant evidence which is there that there do occur in situ thrombosis in these cases because of abnormal hemodynamics. Therefore, oral anticoagulation has a significant role to play, but it is a far significant role to play in group 4 pulmonary hypertension, where you see primary problem is because of chronic thrombopulmonary embolic disease, where it is mandatory to give these patients oral anticoagulation, and wherever needed and required, surgery may be the answer. Role of diuretic, there are no randomized trials, but whenever person has an evidence of right heart failure, they are found to be effective. Oxygen administration has been demonstrated to reduce pulmonary venous resistance in patients of pulmonary arterial hypertension, and more so in group 3 cases where hypoxemia is the primary cause of pulmonary arterial hypertension. But there is no long-term data suggests that in the pulmonary arterial hypertension group it has a significant effect. Digitalis and other cardiovascular drugs, though not greatly, has been tested, but people do try to use inotropes and digitalis in the setting where you are having a person have a significant RV dysfunction or failure, but there is no convincing data that it is a FEL, but yes, if heart rate is high, then probably you may use them to slow the ventricular rates. Anemia is not uncommon in these patients, and therefore we must need to, because in cases of pulmonary arterial hypertension, we are dealing it in the settings of either connective tissue disorders or idiopathic or in young females. Therefore, anemia is not uncommon, and it may cause any hemodynamics abnormalities. So correct that it is always a good strategy to treat anemia. These are the recommendations of the supportive therapy, and it is a summarized form what we have discussed till now. Now let's look at the differential diagnosis of pulmonary arterial hypertension, that is a group T PH. This is secondarily to commonly we see the left heart diseases like chronic left atrial and pulmonary venous hypertension, which we see. Classical example in our country is rheumatic heart disease, and this may include both systolic diastolic function and valvular heart disease, as I gave you an example of mitral stenosis. Therefore, the primary treatment here continues to be the treatment of a valvular disease or management of systolic or diastolic dysfunction. Therefore, the treatment in this group of PH actually shifts from the pulmonary artery to the etiological agent or the etiology which has caused abnormal pulmonary hypertension. When you look at a group 3 pulmonary hypertension, this is commonly along with the hypoxemia or patients of COPD or persons of other lung disorders which have led to significant hypoxemia, or what we see commonly associated sleep disorder breathing or obesity hypoventilation syndrome. Therefore, again the treatment in these cases will be the primary cause which has caused hypoxemia plus the management of hypoxemia, because this is one group of patients where oxygen therapy and the long-term oxygen therapy has been shown to be of great help. In one of the trials which was published in Lancet in 81 and also in 1975 by the MRC and NIH trial have shown consistent benefit of long-term oxygen therapy in the management of pulmonary hypertension in patients of COPD who have a significant clinical hypoxemia defined as less than PO2 of 60 millimeters, or any other case who has got PO2 of less than 55 millimeters of mercury. Now, group 4 PH again is the most important differential diagnosis of pulmonary arterial hypertension irrespective of the age. With the advent of with the CTPA, we are finding more and more cases of chronic thrombopulmonary embolic disease. And it is important to pick up this particular variety of pulmonary hypertension because it is potentially treatable. In these cases, we have to give oral anticoagulation, and along with it, we need, if need arises, and we find there is a significant clot, etc., there a surgery in terms of pulmonary arterial endarterectomy has a significant role to play. And the mortality has come down significantly. It is less than today, though I've written 10% here, but if it's good centers, even it is coming down further. Now, which patient needs to be sent to the referral centers? Because as I said earlier, that right heart catheterization is important, and what is equally important to do a vasoreactivity testing. Quite a few centers in our country are doing it. Therefore, it will be a good practice if you suspect a diagnosis of a pulmonary arterial hypertension, send it to a center where vasoreactivity is being done. It is a good practice to test vasoreactivity not only from the perspective of making a diagnosis, but it is mandatory today in patients of idiopathic PAH. Idea is to identify the patients who will respond favorably to the long-term treatment with high dose of calcium channel blocker. In simple words, whenever you make a diagnosis of pulmonary hypertension, you have been able to exclude the idiopathic, you have been able to exclude the secondary causes of pulmonary hypertension, and you make a diagnosis of idiopathic pulmonary arterial hypertension, then it is important for us to do a vasoreactive test. So if it is positive, then we can put these patients on calcium channel blockers. If it is not, then we should look for alternate strategies of treatment. Similarly, it can also find it out whether these patients will be benefited by prostacyclin or not. Now, therapy, when you talk in terms of pulmonary hypertension, there has been a steady improvement over last couple of years, or more so during last decade. In 1998, it was apart from calcium channel blocker, there were no other drugs. The only other drug approval at that time was IV prostacyclins, that is epoprostenol. In 2010, when the third World Symposium took place, we had expanded the algorithm, and what we found, the additional prostanoids, that we had two more group of drugs, that was endothelin receptor antagonist bosentan, which has come up, and PDE5 inhibitors in the form of sildenafil had also come up. Then in 2008, at an interval 5, we had an addition of 4 additional compounds, and last meeting, which took place in 2013, we had 3 new oral drugs which have become available. That is macitantane, which is a part of endothelin receptor antagonist. Then we had a reasoguat and treprostinil, that is again part of prostacyclins. When you look at a calcium channel blockers, my dear friends, only a small number of patients which have a favorable response will do well with calcium channel blockers. Predominantly, people have used either nifedipine, diltiazem, or amlodipine. And the choice actually depends upon what is the basic rate of heart rate in the patient. If person is a relative bradycardia, obviously you will not choose diltiazem. On the relative tachycardia will favor diltiazem, and bradycardia will lead in favor either nifedipine or amlodipine, that is dihydropyridine derivatives. The doses which make difference in this are relatively high, and usually systemic hypotension and an ankle edema or ankle swelling is a common side effect. If you find response is inadequate, then you need to add additional drugs. Adequate response usually is defined by WHO, and that there has to be a significant hemodynamic improvement. In other words, before starting you have to do a hemodynamic measurement, and it will be a good clinical practice, though may be difficult sometimes, to measure hemodynamics at 6-monthly interval. And another thing important is that vasodilator responses may be helpful in terms of deciding the drug, but they does not appear to predict a favorable long-term response in patients, especially in the settings of connective tissue disease, HIV, portopulmonary hypertension, and pulmonary venous occlusive disease. That's an important point to remember. Now, these are the recommendations which we have discussed and talked. It's a brief which is given there. What is very important is that you recommend them in idiopathic or hereditary pulmonary arterial hypertension. That is where, but level is only group C recommendation. Again, you need to have a close follow-up at 3 to 4 months of a therapy, as I said, with the right heart catheterization. And lastly, which is in the red zone, you should remember, is not indicated in patients without a vasoreactive study or non-responder unless standard doses are prescribed for other indications. That means you are giving it for Raynaud phenomena, you justify for it, but not primarily for the pulmonary arterial hypertension. Another group which is being commonly used is an endothelin receptor antagonist. Now, activation of this particular system has been seen in both plasma and lung tissues of pulmonary arterial hypertension. Now, whether it is a cause or a consequence is still a jury is out. Endothelin 1 is a vasoconstrictor and also has a positive mitogenic effect. Now, it binds to these receptor forms. When we are looking at endothelin receptor antagonists, they bind to 2 isoforms on the pulmonary smooth muscles, that is endosreptor type A as well as B. One of the common drug which is nowadays being used is ambrinstan, and this is basically attached to receptor A, and it has a significant efficacy on symptoms, exercise capacity, has a positive impact on hemodynamics, and also decreases it increases the time to clinical worsening of patients with IPH and pulmonary arterial hypertension, whether they are associated in idiopathic or in connective tissue diseases. So it's a good choice drug in pulmonary arterial hypertension, whereas bosentan is a non-specific and works in both type A and type B. Now we have a different randomized trials have taken place which have all shown to be showing benefit of endothelin receptor antagonist. Mesentan is a new drug and also reduces significant composite endpoints of morbidity and mortality. Again, in this case, we are seeing that the benefit is in both patients who had not received previously and for those receiving additional therapy. So you can start it in a drug naive or already a patient who are receiving the treatment. Therefore, it's a significant advance which is there. But important issue is that it can have hematotoxicity, whereas bosentan and ambrisentan has a significant liver dysfunction and they need to be monitored. Phosphodiesterase type 5 inhibitors and guanylate cyclase stimulators are an additional two different categories of drug, but they have both a significant hemodynamic effect on the pulmonary vasculature. Inhibition of CGMP degrading enzyme phosphodiesterase type 5 results in vasodilatation through NO-CGMP pathway. In other words, both of them work through the nitrous oxide CGMP pathway. One is a stimulator of that pathway, NO-GMP. Another is also increases the value, but by inhibiting the enzyme which leads to the degradation of cyclic GMP and nitrous oxide pathway. So both of them and ultimately help by increasing the level of nitrous oxide so that there is an increased vasodilatation. In addition, PDE5 has a significant anti-proliferative effect. Today we can have a list of sildenafil, tadalafil and vardenafil which are available, and they have led to significant improvement in pulmonary hemodynamics. Riociguat, which is a cyclic GMP stimulator, what we are finding it also have anti-proliferative and anti-remodeling properties in various animal models. So that's a significant advance, that not only it prevents the proliferation, but it actually can prevent the remodeling of the pulmonary vasculature from reversible to irreversible condition. A randomized controlled trial which was done in 443 patients of pulmonary hypertension by riociguat 2.5 milligram, what they have found out is that it reduces the functional classification or deterioration and help the patient significantly. The most common serious adverse effect in these patients actually is syncope. Combination of these two drugs is contraindicated, though they may have a different level of mechanism of action, but end result is the same. Therefore, they may cause significant vasodilatation and syncope. Prostacyclin analogs and prostacyclin receptor agonists are another armamentarium. Prostacyclin is a drug which prostacyclins are released from the endothelium and are responsible for the vasodilation of the pulmonary vessel and all the vascular beds. In addition, the compound most part is again inhibitor of platelet aggregation, therefore they can help in preventing in situ thrombosis in these cases. They have found also to be both cytoprotective as well as anti-proliferative properties. Drug in this category, oral drug is only one available, which is a Beraprost, and then you have to use epoprostenol by infusion, and iloprost is available for both IV oral aerosol administration, but still it is not available in India as far as the aerosol preparation is concerned. Additional drug which have of late come is a treprostinil, a tricyclic benzidine analog of epoprostenol, and it can be given IV and subcutaneous, inhaled and oral routes. The new drug selexipag, which is there, is orally available. It selectively prostacyclin IP receptor agonist, which is there, and mode of action is similar to that of endogenous prostacyclins. And it has been found to reduce PVR, that is pulmonary venous resistance, vascular resistance in these patients. Now let us look at the recommendations for the pH by as per WHO functional classification. Calcium channel again has to be drug to be used primarily as a monotherapy either in group 2 or group 3, whereas endothelin receptor antagonists are recommended primarily as a group A drug for functional class 2 and functional class 3 WHO, whereas as far as the functional class 4 they can be used but not a drug of choice. Same is true for phosphodiesterase inhibitors. This is a group A recommendation as far as patients who have got functional class 2 of pulmonary arterial hypertension. On the other hand, in functional class 4, though they can be used, but they may not be the drug of first choice. In other, efficacy may not be as much as you see in patients who have got functional class 1, functional class 2 and class 3. On the other hand, the new drug, riociguat, which is a guanylate cyclase stimulator, is nowadays recommended also for functional class 4. However, the drug continued to be of a choice in advanced pulmonary arterial hypertension with significant right ventricular dysfunction is actually intravenous epoprostenol. However, now with the availability of new prostacyclin drugs or the receptor agonist, you probably can use them, but we still need to have more data to say whether they are significant recommendation in terms of evidence A or B. That is what we are still looking at it. On the other hand, IP receptor antagonist Selexipag, primarily people still recommending group 2 and group 3, they are still not being recommended for group 4. Therefore, in nutshell, all these drugs can be used in WHO functional classification 2 and 3. If we have to use any of these drugs as in functional class 4, drug of choice still continues to be intravenous epoprostenol. However, because of the difficulty in giving this drug, it is alternate drugs which nowadays, though evidence is not as strong as for that, are actually you can use it from either endothelin receptor antagonist or phosphodiesterase type 5 inhibitors, or from prostacyclin analogs and Riociguat, which is a guanylyl cyclase stimulator, which is there. Combination therapy can also be used where you try to put two drugs of different groups together to have an additive effect. Now these are, or alternately you can use them in a sequential combination, but today that is the most widely used strategy. Experimental strategies which people are trying to use in this is tyrokinase inhibitors, gene therapy or stem cell therapy. Surgical intervention as far as pulmonary arterial hypertension is concerned is only kept for the severe PH patients who are not respond with advanced therapies. In these cases, people are either doing a balloon atrial septostomy, that is a creation of a small hole between the right and left atria to reduce the pressure on the right side. But the definitive treatment continues to be either a heart-lung transplantation or a heart transplantation. Now, if you start looking at a treatment algorithm, let us summarize it. First and foremost is why we need to look at it, whether a person has got a PH or not. That means once we have confirmed the diagnosis of pulmonary arterial hypertension, general measures have to be put as discussed earlier in all the patients. Then we should do a right heart catheterization and look for vasoreactivity, whether person has got acute reactive vasoreactive test is positive or not. If it is positive, then you can put these patients on calcium channel blockers. Therefore, diagnosis and management of pulmonary arterial hypertension not only needs an intimate knowledge of cardiorespiratory physiology, but also needs a multidimensional team approach for its diagnosis and management. Thank you for patient listening.